I will have the pleasure to have my friend Greta Dreyer, the president-elect of IGCS, to give, fresh from Seoul, the highlights from IGCS 2023. Greta, the floor is yours.
Thank you, David, and thank you again for having me. My approach will be a little bit different, and thank you, Anna, for starting this highlights session for us. We had the chance to a little bit collaborate, and hopefully will not overlap too much. I think there's one study that I actually also listed. But I would like to show you a little bit of short summaries of what was discussed, and I hope it will be of interest. So first, there were a few trials and interesting things that were not specifically linked to a specific tumor type. And the first thing that I decided to just bring to the crowd here, and specifically to those of you who could not be in Seoul, Korea in November, was actually just the impact and the importance of the presidential plenary, where Keiichi Fujiwara brought to our attention once again, and I think this is something that we very often miss in gynae-oncology, highly scientific meetings, the importance of relieving the serious health-related suffering in women with gynecologic cancers. And I think this was a very important and even pivotal presidential plenary. The design was really that he had speakers focusing on palliative aspects of care and specifically on the WHO public health model. I think the effect was that the increased awareness, improved also and just drew attention again to the importance of the multidisciplinary collaboration. And here specifically, I think the importance of nurse oncologists were really highlighted. And the session ended by a pledge and a call to action from everyone present. Then I thought it was really important to see, and I really will bring those few snippets to you that was interesting to me and was important, and I think that is a little bit practice changing, or at least highlights that we will be watching with a hawk's eye in the future. This study, based on the Destiny Pan-Tumor 02 group, was a phase 2 where only patients with immunohistochemistry 2+3+ positive HER2 in gynecologic cancers were included. 120 of them, sorry, that second sentence actually belongs to another slide. Then the important results were, number one, that the safety was really the same as what we know the safety profile of Herceptin is. The important thing, of course, is the interstitial lung disease that one needs to watch out for. And then they really had an encouraging survival benefit for patients according to HER2 expression levels. And here you can see the endometrial cancer group, according to HER2 expression levels, had a highest response rate in those with the most HER2 expression and lower down, and also the ovarian group. You can see once again that also in gynecologic cancers, HER2 is an important marker for Herceptin response. The other important thing is the overall response rate, especially in endometrial cancer, is very, very encouraging. And you can see that 85% in patients in the selected group there of endometrial cancers really responding very well. So I think that is super important and probably practice changing, and in fact in that we really need to start looking at the HER2 status of our tumors, especially endometrial, and that we start to have to start incorporating this drug where we haven't before. I think another highlight of the meeting was actually the beautiful place where the meeting was held, and this is just an aerial photo of Korea, and it really looked like that from the top floors of the high hotels. Also, the fact it was actually autumn, and the hotel looked out on this beautiful ancient temple. So in terms of ovarian cancer, the Lance trial focused on whether laparoscopy is feasible for secondary cytoreduction. Now, they did include only stage 3C and 4 epithelial ovarian cancer after induction chemotherapy, and only those where the CA125 has normalized. 100 patients prospective multicentric trial where minimally invasive was compared to open surgery. I think it is of interest that 20% of these patients in both arms actually had HIPIC previously, and also there was 30% of the patients actually had stage 4 disease. The laparoscopy arm had a 12% conversion rate, which is really considered acceptable, and then the other complications were really between the two arms open laparoscopically done completely comparable. Very high rates of complete cytoreduction was reached, and 4% serious adverse events in the minimally invasive arm. So the authors conclude, and I think it is a fair conclusion, that in this highly selected group of patients, in this first phase of the trial, laparoscopic secondary cytoreduction seems to be feasible with an acceptable conversion rate and an acceptable complication rate. And that's really just data, and I'm not going to show you too much, maybe other than to just show that the intraoperative complication rate was actually very low, and with the 6% that really had intraop problems. So the second study in ovarian cancer I want to share with you is a follow-up analysis from the charity group, where they actually now reanalyzed patients previously excluded from the analysis of the Lions trial. And I think the Lion trial is really pivotal in that it changed our mind about lymphadenectomy as part of cytoreduction in ovarian cancer. But the Lions trial actually excluded all patients where the surgeon considered the surgery as not doable, or when the patient actually had suspicious nodes intraoperatively. So this group now reanalyzed those patients excluded due to these two problems. And they had 200 patients that were now eligible for this reanalysis, which is really a large group. The interesting thing is that there was actually 60% of clinically suspicious nodes were positive on histology, meaning that of all nodes that you actually consider suspicious, at least 40% of them will actually be negative on histology. And then the other thing is that there was only a 45% complete response rate on histology, and this is sort of in line with what we know about induction chemotherapy. The important end result of this reanalysis is also in this subgroup where surgery is considered not doable or where the lymph nodes look suspicious, there is no therapeutic benefit in removing those lymph nodes to actually improve outcomes. The Gorilla group is a surgical group in Korea. We probably know them quite well. They did a very interesting retrospective review. Now, many of us do our own bowel surgery, and some of us have a general surgeon working with us. Some of us do it sometimes, and other times we call a friend. The question that the Koreans asked was, does it make a difference to the outcome? Both the morbidity and also the oncological outcomes, whether a gynae-oncologist does the bowel resection or a general surgeon does it. Now, I think it's interesting, and especially large bowel then, and I think most of these were probably sigmoid resections. interestingly, even in this trial, the vast majority of the bowel surgery was done by general surgeons. But actually, they found no difference between the two groups, which surgeons they did. There was actually a better survival, and I think this is somehow logical, but it's also important for us to remember there's a better prognosis if you have to do bowel surgery at primary surgery for ovarian cancer than if there is still a need to do bowel surgery at your interval site of reduction. And interestingly, the gynae-oncologists were more involved with the primary surgery and therefore actually did more of those patients, and therefore they had better oncological outcomes due to that bias. So the final result is that they found no oncological difference and found that it was feasible and safe. So as long as you're well trained, you can do your own bowel surgery. This is the night view of Korea, and we're moving to endometrial cancer. We did, once again, we had this in FIGO, we had it at ESGO, etc., had an update or an interactive session of the new FIGO endometrial staging update presented to us by members of the FIGO Oncology or Cancer Committee. And they really talked about how and when and where the update was done, and also discussed quite thoroughly what was changed and how it was changed, the pathological staging and the molecular staging, and certainly trying to convince the audience to follow the new FIGO staging for endometrial cancer and to integrate it into our practices. Of course, there is a bit of a resistance to that staging due to the complexity. I think if we are considering sentinel lymph node mapping in endometrial cancer, there's always been a question whether this is also suitable for high-risk endometrial cancer. And this group actually, the group of Bjorn Holt, actually showed that there is a need to have a different protocol for these patients because high-risk endometrial cancer sentinel lymph node mapping cannot follow the normal sentinel lymph node mapping because of the sensitivity and specificity issues, but specifically more so the sensitivity. And the reason is that 20 to 45% of patients will actually fail mapping. What they did was they tried then to suggest a new algorithm, and I think this is interesting and something that we should watch and perhaps follow. They said that adding the removal of the PET positive nodes to those patients, those nodes that map, increases the sensitivity. So if you have successful mapping, you still add those positive on PET. If you have unsuccessful mapping, you should actually do a full lymphadenectomy with PET mapping, but they say pelvic only. If you have unsuccessful mapping, but no PET result, you should actually do pelvic lymphadenectomy plus para-aortic lymphadenectomy, and then you will reach the same sensitivity. So I think this is a very interesting new algorithm, and it points towards differences in tumor biology needing different treatment approaches. I've also listed the selinexor study, and I think this is highly interesting. I think what was not said before is actually the serious adverse events with bone marrow, nausea, diarrhea. That is really all important side effects of this drug, and that 16% actually discontinued the drug due to the side effect profile. But most certainly highly significant improved performance-free and overall survival, and actually independent of the microsatellite stability status of the tumor. We still see a really, really good response. So this is one of the few new drugs for endometrial cancer that is on the horizon. I wanted to show you the beautiful painting work on the ancient temple wooden platform there, and really a very serene and beautiful area. The interlaced trial has been alluded to this morning with the induction chemotherapy before chemoradiation therapy, and I think many people are very ready to accept the results and to include it. And that is also the idea and the opinion of the authors, that it is a new standard of care. Maybe we should be a little bit careful, but the overall survival benefit is clear in this study. I think it will be interesting to see if other studies actually show the same result. And then the addition of pembrolizumab to chemoradiation for stage 3 and 4 has also been alluded to, and it's also considered a new standard of care. I think lastly, I think it is interesting that the minimally invasive surgery in cervical cancer still attracts a lot of attention, and there are still many people and many trials and many investigations going on to try and understand the poor outcome or the higher rates of recurrence after minimally invasive surgery. And this Korean study actually looked at their recurrence rates, and they actually found the same as in many other trials, and specifically peritoneal metastasis is a problem in minimally invasive, and they tried to understand why. What they found was that conization in itself did not protect, but that patients with no residual disease after conization actually had a very low recurrence rate in the peritoneum as well. I thank you. These are the cliffs of Moher. And I also want to invite you to Dublin next year, October. Thank you.